Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to The Deep Dive, the show that cuts through the noise and gets you straight to the really fascinating facts you need to be truly well-informed.
Glad to be here.
Today, we're tackling something incredibly common, major depressive disorder, MDD. Huge global challenge.
Absolutely.
And antidepressants have been, well, instrumental for millions.
Yeah.
But here's the twist, the part that's often less discussed. The significant impact these drugs can have on sexual health.
That's right. And that's our mission today, really, to unpack the different effects of various antidepressant classes.
Specifically
SSRIs, that's selective serotonin reuptake inhibitors.
Okay.
And NDRIs, the norepinephrine dopamine ones. We're looking at how they affect male sexual function.
So we're digging into the sources, pulling out the key insights.
Exactly. Why these effects happen, which meds carry the highest risk, what can actually be done.
And you mentioned a specific syndrome.
Yes, we'll definitely get into a particularly persistent and, frankly, challenging syndrome later on.
Okay, important context first. We know depression itself can mess with sexual function, right?
Definitely. That's a crucial baseline point.
But today, we're zeroing in on antidepressant-induced sexual dysfunction.
Yeah.
AISD.
Yes. And it's not trivial, it's common, it's distressing for people.
And a major reason people stop their meds, which is a huge problem. Risk of relapse.
Absolutely demands attention. So to understand how these meds disrupt things, we need to know how it normally works.
The baseline function.
Right. The normal male sexual response. It's complex, a coordinated cascade, multiple systems involved.
Like a four-part symphony, maybe?
Good analogy. First, you've got libido, sexual desire.
The mental part. Thoughts, fantasies.
Exactly, the conscious motivational bit.
Yeah.
Influenced by hormones like testosterone and brain processes, where it all starts.
Okay, part one.
Part two, erection, arousal. This is neurovascular. Signals release nitric oxide, NO.
Nitric oxide, okay.
Which relaxes smooth muscles, allows blood flow in, creates firmness, getting the signals right.
Got it. Libido, erection. What's next?
Ejaculation, that's a two-phase process. Sympathetic nervous system is key here.
And moving fluid, muscle contractions.
Precisely. Emission, then expulsion.
And the finale.
Orgasm, the intensely pleasurable sensation. Subjective in the brain. Usually happens with ejaculation, but it's technically distinct. A separate neurological event.
Okay, so four parts. But what conducts this symphony? What makes it work or fall apart?
Neurotransmitters, that's the key. A delicate balance. Think of it as a team managing excitation and inhibition in the brain.
A neurochemical balancing act.
Exactly. And the roles are quite distinct. Dopamine, that's your primary prosexual player.
Prosexual, meaning?
It drives motivation, reward, pleasure. The mesolimbic system, essential for libido, for that feeling of a satisfying orgasm. Dopamine's the gas pedal, in a way.
Okay, the accelerator. So what's the brake?
That would largely be serotonin. It's predominantly inhibitory.
Inhibitory across the board.
Pretty much all phases. High serotonin, especially via certain receptors like 5-HT2A, 5-HTTC, it suppresses sexual behavior, mainly by inhibiting dopamine release. Puts the brakes on dopamine.
Okay, so it directly counters the prosexual driver.
Right. Plus, it acts in the spine, too, can delay or block orgasm and ejaculation.
Makes sense. What about the third one, norepinephrine?
Norepinephrine is more complex, dual role. Centrally, you need it for alertness, general arousal. You need to be awake and alert for sex.
Yeah.
But peripherally, too much sympathetic activity driven by norepinephrine is actually anti-erectile.
Anti-erectile. How so?
Think about erections during sleep, REM sleep. That's when sympathetic activity is lowest. Too much fight or flight signal isn't good for maintaining an erection.
Okay, so dopamine pushes go, serotonin pushes stop, norepinephrine is complicated.
A good summary. And normal function depends on keeping these in that fine-tuned balance.
So here's the crucial link then. What happens when these antidepressants deliberately, powerfully shift that balance, especially the ones hitting serotonin hard?
That's the aha moment. When a drug massively increases an inhibitor like serotonin sustainedly, It's not a minor tweak. It's a fundamental disruption.
So AISD isn't some weird, unexpected side effect.
Not at all. It's a predictable neurobiological consequence of how these drugs fundamentally work. It's almost baked in.
That reframes things significantly. It helps explain why different classes have different impacts.
Exactly. Let's define those classes quickly.
Okay, SSRIs first. Selective serotonin reuptake inhibitors, like Prozac, Zoloft, Paxil.
Fluoxetine, sertraline, paroxetine, citalopram, yeah.
Right.
They block the serotonin transporter, SERT. More serotonin stays active in the synapse. Simple mechanism, powerful effect.
More serotonin. Got it. Then SNRIs,
Yeah.
serotonin norepinephrine reuptake inhibitors.
Right. Venlafaxine, Effexor, duloxetine, Cymbalta, desvenlafaxine, Pristic, dual action, block reuptake of both serotonin and norepinephrine.
So they boost both.
Yes, though individual drugs vary in how strongly they hit each one. That difference matters.
And the third class, NDRIs.
Norepinephrine dopamine reuptake inhibitors, mainly bupropion, Wellbutrin. Very different profile.
How so?
Inhibits norepinephrine reuptake and dopamine reuptake to a lesser extent, but critically negligible effect on serotonin.
Avoids the main brake system we talked about.
Precisely, that's the key distinction.
Okay, so let's connect those mechanisms back to the dysfunction, specifically the serotonergic kind from SSRIs and SNRIs.
The core issue is central dopamine inhibition. Remember how serotonin inhibits dopamine?
Yeah.
Well, the flood of serotonin from these drugs stimulates those inhibitory receptors, 5-HT2A and 5-HT2C, on dopamine neurons, especially in reward circuits like the VTA and nucleus accumbens.
So it clamps down on dopamine release in the very areas responsible for reward and motivation.
Exactly. It effectively dampens dopamine signaling right where you need it for sexual function.
And that explains the symptoms people report. Low libido, trouble with arousal.
Diminished libido, impaired arousal, and that really unpleasant, blunted, or pleasureless orgasm, it maps directly.
You mentioned pharmacovigilance studies.
Yes, large studies show a clear link. The more potently a drug blocks serotonin reuptake, the higher the reports of decreased desire. It's quite direct.
Are there other effects besides the brain?
Yes, there are peripheral and spinal effects too. That increased serotonin tone in the spine can delay ejaculation.
Which is sometimes used therapeutically for premature ejaculation.
It is, but for many others, it's an unwanted side effect. And some SSRIs, like paroxetine, might also directly inhibit nitric oxide synthase.
The enzyme needed for erections.
Right. So that could contribute to erectile dysfunction too, multiple hits.
Okay, so that paints a pretty clear picture for the serotonergic drugs. How does bupropion, the NDRI, contrast so starkly?
Because it works entirely differently. It enhances the prosexual neurotransmitters, dopamine and norepinephrine.
The go signals.
Right. And it completely avoids that inhibitory serotonin system, skirts the whole problem area.
Which is why it doesn't usually cause these issues.
Not only that, it's often used specifically to counteract sexual side effects caused by SSRIs. It works in the opposite direction, functionally speaking.
So this really highlights a fundamental clinical challenge, doesn't it? The neurotransmitter trade-off.
Absolutely. Boosting serotonin can be very effective for depression or anxiety, but it comes with this predictable neurobiological cost to sexual function.
While boosting dopamine preserves sexual function, but has a different therapeutic window and its own side effects.
Exactly. There's no single best antidepressant for everyone. It forces a strategic choice, a conversation between doctor and patient about priorities.
A truly patient-centered discussion. Okay, we've covered the why. Let's talk about the how often. What does the hard data show? How common is this in the real world?
Yeah, the numbers are quite revealing. Getting precise figures used to be tough. Lots of underreporting.
People are embarrassed. Maybe doctors didn't ask directly.
Both. But newer, larger studies using direct questioning give us a much clearer picture, and there's a definite hierarchy of risk.
Let's start at the top. SSRIs. What do we look at?
Consistently high risk. Treatment-emergent sexual dysfunction, meaning it started after taking the drug, occurs in anywhere from 25% up to 80% of patients on an SSRI.
80%, that's staggering.
It is. Compare that to placebo rates, which are much, much lower. A landmark meta-analysis over 10,000 patients really laid it bare.
Give us some examples.
Okay, sertraline, Zoloft, 80.3% total sexual dysfunction. Odds ratio compared to placebo, 27.4.
Wow. 27 times more likely than placebo.
Citalopram, Celexa, 78.6%. Odds ratio, 20.3. Paroxetine, Paxil, 71.5%. or 16.9, fluoxetine Prozac, 70.6%, or 15.6.
So for SSRIs, it's really common.
It's often described as the rule rather than the exception. Significant sexual side effects are expected for many, many patients.
Okay, what about the SNRIs? You said the risk there is more variable.
It is. Venlafaxine effects are, especially at lower doses where it acts more like an SSRI, is right up there. 79.8% dysfunction or 24.8. Very similar to the SSRIs.
But others are lower.
Yes. Duloxetine Cymbalta is more moderate, 41.6% or 4.3. Still significant, but less than half the rate of venlafaxine or the SSRIs.
And newer ones.
Some newer SNRIs, like levomilasoprans, seem to have even lower rates, maybe 5–6%, possibly because they're more selective for norepinephrine versus serotonin.
Interesting. Which brings us to the NDRIs, the propion.
The clear outliers.
Yep.
Lowest risk by far. Total sexual dysfunction rate, 10.4%.
And how does that compare to placebo?
Get this. The placebo rate in those studies was 14.2%. So bupropion's rate was statistically indistinguishable from placebo, odds ratio 0.8.
Basically, no different than taking nothing in terms of sexual side effects.
Pretty much. And again, it comes back to that non-serotonergic, pro-dopaminergic mechanism. The data strongly supports the neurobiology.
That's a stark difference across classes. But then there's something even more concerning you mentioned earlier.
Yes. We need to talk about post-SSRI sexual dysfunction, PSSD.
Post-SSRI, meaning after stopping the drug.
Exactly. The persistence or sometimes even emergence of sexual dysfunction after discontinuing a serotonergic antidepressant, an SSRI or an SNRI. And it's completely separate from the original depression.
That sounds alarming. What are the symptoms?
They mirror the acute side effects, but they just don't go away. Decreased libido, erectile dysfunction, weak or pleasureless orgasm, sometimes called anhedonic orgasm.
Anhedonic, meaning without pleasure.
Right. And crucially, often a really distinct symptom. Genital anesthesia or numbness,
Yeah.
a loss of sensation.
Numbness, that's very specific.
Very specific and very distressing. Non-sexual symptoms like emotional blunting can also persist.
How long does this last? Is it like a prolonged withdrawal?
That's the deeply worrying part. It's not just withdrawal. Symptoms can be debilitating and incredibly long-lasting. Some reported cases go on for years, even decades after stopping the medication.
Years?
Yeah.
Decades? That's terrifying. Is this officially recognized?
It's gaining recognition, yes. Major regulators are taking notice. The European Medicines Agency, the EMA, mandated warnings back in 2019.
Warnings on the drug labels.
Yes. And Australia's TGA, their equivalent, followed suit in 2024. They now require warnings about persistent sexual dysfunction after stopping SSRIs and SNRIs.
So what's thought to be going on here? If it's not just a temporary imbalance, what could cause such lasting effects?
The proposed mechanism suggests it might be less of a temporary software glitch and more of a lasting hardware change in the nervous system.
Hardware change, like actual structural changes.
Potentially. Theories include things like epigenetic modifications, long-term changes in how genes are expressed, or serotonin neurotoxicity, actual damage to nerve cells, or persistent changes in receptor sensitivity.
Receptor changes.
Yeah, like receptors getting permanently downregulated or desensitized from the prolonged drug exposure.
Yeah.
There was a fascinating animal study just published this year, 2025.
What did it find?
Rats treated with paroxetine showed reduced dopamine levels and altered dopamine gene expression in the nucleus accumbens, that key reward center. And these changes persisted for at least a month after the drug was stopped. It suggests lasting alterations.
A biological footprint left behind.
Potentially. And that genital anesthesia symptom. One compelling theory is drug-induced small fiber neuropathy, damage to the small nerve fibers that transmit sensation.
Wow. Okay, if it's potentially this severe and lasting, why isn't it more widely known or studied?
There are significant barriers. Ethically, you can't do a randomized trial where you give people a drug hoping they develop a persistent negative side effect after stopping it.
Of course not.
And the existing questionnaires used in drug trials weren't really designed to pick up PSSD's specific features, especially that numbness. Plus, historically, drug companies didn't do long-term follow-up after patients stopped the medication in trials.
So the data just wasn't collected systematically.
Right. And then there's a clinical side. Underreporting is huge. Patients feel embarrassed, ashamed.
Or maybe they think it's just their depression coming back.
Exactly. Or worse, they are told that by doctors. Their symptoms get dismissed as residual depression or anxiety or just in their head.
That must be incredibly invalidating.
Terribly so. And it prevents accurate reporting and understanding of how common it might be. One preliminary study from Israel estimated maybe 1 in 216 males, about 0.46% develop PSSD, but that's almost certainly an underestimate given the reporting issues.
The implications here are massive, aren't they? It challenges the whole idea that side effects just stop when the drug stops.
It really does. It shifts the perspective from maybe a temporary software issue neurotransmitter levels to a potential hardware problem, altered neural structures or function.
Which changes the risk-benefit calculation completely.
Especially for milder conditions or for young people whose nervous systems are still developing, the potential for long-term irreversible changes has to be considered.
So given all this complexity, the acute side effects, the risk of PSSD, how should clinicians and patients actually navigate treatment decisions?
Proactive assessment and management are absolutely key. You can't just wait for problems to appear.
What does proactive mean in this context?
It means assessing sexual function before starting any antidepressant. Get a baseline.
Why is that so important?
To differentiate what might be due to the depression itself versus what's caused by the treatment, it also crucially opens the door for that conversation from the start, normalizes talking about it.
Makes sense. Are there tools to help with this?
Yes, using validated questionnaires are really helpful for tracking changes over time.
Like?
The Arizona Sexual Experiences Scale, or ASEX. It's brief, just 5 items. Drive, arousal, erection, orgasm, satisfaction. There are clear scoring cutoffs for clinically significant dysfunction.
And easy to use?
Relatively. Or the Changes in Sexual Functioning Questionnaire, CSFQ. It's a bit more detailed, 14 items. Again, clear scoring for men, a total score below 41 signals dysfunction. Using these tools standardizes assessment.
Okay, so you've assessed, maybe used a tool, and identified AISD. What then? What are the actual strategies?
Needs to be individualized, always a shared decision between patient and doctor. But the main options are
waiting it out. Does it get better on its own?
watchful waiting is usually the least effective strategy. Only a small minority, maybe 10–15%, develop tolerance where the side effects fade over time. Not great odds.
Okay, so what else? Lowering the dose.
Dose reduction can sometimes help, sure, but the big risk there is losing the antidepressant effect, potentially triggering a depressive relapse. Tricky balance.
Right, so maybe switching drugs.
Switching antidepressants is often the most effective approach. Moving to an agent with a different mechanism and lower risk profile.
Like switching to.
Bupropion is the most strongly supported switch, given its very low AISD risk. Other options with lower rates include mirtazapine or vortioxetine.
Okay, switching is one route. What about adding something? Augmentation.
Yes, augmentation or antidote strategies can work. Adding bupropion, 150–300 milligrams a day, to an existing SSRI is well studied. It can help counteract the serotonin effects, boosting libido, arousal, orgasm.
Adding the go signal back in.
Essentially. Another option specifically for erectile dysfunction is adding a PDE5 inhibitor.
Like Viagra or Cialis. Sildenafil, tadalafil?
Exactly. They are highly effective for the erection part, but they won't touch low libido or problems with orgasm. They only fix the plumbing, so to speak, not the desire or pleasure signals.
Important distinction. What about skipping doses, like a drug holiday?
That's sometimes suggested, maybe skipping a dose before planned sexual activity, but it's risky. Potential for withdrawal symptoms, and again, risk of relapse if doses are missed frequently. Generally not ideal.
Seems like switching or augmenting with bupropion are often the preferred routes.
They tend to have the best evidence base for effectiveness and managing the underlying mechanism.
We've talked a lot about the clinical side, the mechanisms, the data. But let's talk about the human side, the actual lived impact.
Absolutely crucial. This isn't just about symptom checklists. AZ profoundly impacts quality of life.
How so?
It puts immense strain on intimate relationships, leads to feelings of inadequacy, frustration, emotional distance between partners.
I can imagine.
And for men, specifically, sexual function is often deeply tied to identity, masculinity. So experiencing these problems can create a real conflict with masculinity and self-concept. Feelings of failure, shame.
Which could even worsen the depression itself.
Absolutely. It can become a vicious cycle. And for those with PSSD, the descriptions are just devastating.
Like the ones you mentioned earlier.
Yes. A loss of the ability to feel pleasure, not just sexually, but generally. Anhedonia. Difficulty connecting emotionally, leading to isolation, hopelessness, even suicidality in some cases.
The description, chemically lobotomized.
Or trapped in a cold, hopeless void. These aren't exaggerations for those suffering severely. It highlights the profound human cost.
Which brings us to the ethics of it all. Informed consent.
Yes. The informed consent gap here is staggering. You cited that study as low as 12% of patients recalling being told about sexual side effects before starting the drug.
12%. That's abysmal.
It's a fundamental failure. Patients have a right to know the potential risks, especially common and potentially persistent ones, to make an informed choice about their bodies and lives.
So the standard really needs to be shared decision-making.
Without question, it's a collaboration. The clinician brings the evidence, risks, benefits, alternatives. The patient brings their values, priorities, life context.
Like for one person, maybe rapid anxiety relief is the absolute top priority, even with side effect risks.
Right. While for another, maintaining sexual function and intimacy in their relationship might be paramount, maybe favoring a lower risk drug, even if it works a bit differently or slower.
It's about aligning treatment with the patient's goals.
Precisely. And this is where patient advocacy groups become so important.
Like the PSSD network you mentioned.
Exactly. Groups like that play a vital role. They raise awareness, they provide crucial support for patients who often feel dismissed or gaslit by the medical system.
They're filling a gap.
A huge gap. They also fund research, advocate for regulatory changes, push for better clinical guidelines. They are genuinely contributing to medical knowledge and patient safety, often from a place of lived experience.
Their contribution sounds essential. Looking forward, is there hope for better prediction or prevention? You mentioned genetics earlier.
Yes. Pharmacogenomics holds promise. We're learning more about how genetic variations might influence who develops side effects.
Specific genes.
Genes involved in drug metabolism, like CYP2D6 and CYP2C19, or genes related to the serotonin system itself, like the transporter gene SLC6A4 or the receptor gene HTR2A.
So in the future, a genetic test might predict your risk.
That's the hope. Personalized medicine, selecting an antidepressant based not just on symptoms, but also on your genetic likelihood of responding well, and crucially, your risk of developing side effects like AISD. It could help prevent these issues before they start.
A much more targeted approach.
Potentially, yes. Still early days for widespread clinical use, but the science is moving fast.
Okay, let's try to bring this all together. We've covered a lot of ground in this deep dive.
We have. I think the key takeaways are that clear hierarchy of risk, with SSRIs generally highest, NDRIs like bupropion lowest.
Understanding why that crucial dopamine-serotonin balance and how different drugs disrupt it.
Right, and the profound implications of post-SSRI sexual dysfunction, PSSD, challenging our view of side effects as always temporary.
So the provocative thought for you, the listener, what does knowing all this mean for you?
How does this information change how you approach health decisions, either for yourself or for people you care about?
Does it empower you to ask different questions, to advocate more strongly for your needs and priorities?
To insist on that shared decision-making process we talked about.
The conversation around mental health treatment is definitely evolving. It's becoming clearer that it's not just about feeling better in terms of mood.
No, it's about understanding the full impact on your life, your relationships, your sense of self, and ensuring that your personal priorities, what truly matters to you, are right at the heart of every single treatment choice.
That seems like the crucial message. Understanding the trade-offs, knowing the risks, and making sure your voice is heard.
Absolutely. Knowledge empowers choice.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.